Hi everybody, and welcome to our module on the retina. We'll start by talking about the retina and the macula. The retina is the inner layer of the eye, and it contains photosensitive cells called rods and cones. You can basically think of the retina as the most important part of the eye. All the other structures in the eye are there to support the retina so that the retina can do its job of picking up light and making an image of the world around us for the brain. And the major blood supply of the retina is the choroid. This is a vascular layer that sits beneath the retina, and we'll talk later in this module about how problems can occur if the relationship between the choroid and the retina is disrupted. The macula is an oval-shaped area near the center of the retina, and it contains a structure called the fovea, which has the largest amount of cone cells. And basically, the macula is important for very high-resolution color vision, and you need both your retina and your macula to have normal vision. And in this module, we're going to talk about problems that occur when either the retina or the macula are not normal. Just so you have a clear picture of these structures in your mind, shown on the screen is a drawing of the eye, and this inner red layer is the retina. And if you focus on this portion of the drawing at the top of the picture, the blue layer beneath the retina is the choroid. That's the vascular layer that supplies blood to the retina, and beneath the choroid, this white layer is present, and that's the sclera. Over here is this oval-shaped area, that is the macula, and at the center of the macula, that's where you find the fovea. Fundoscopy is a term used to describe examination of the back of the eye that's part of the physical exam, and it gets its name because the fundus is the back of the eye opposite the lens, and this includes structures like the retina and the optic disc and the macula. So therefore, fundoscopy means a visual examination of the fundus. This is a picture of a normal fundoscopic exam shown on the screen. For the USMLE Step 1 exam, it's very unlikely they will ask you how the retina or the macula work. Instead, what they're going to want you to be able to do is to recognize retina and macula pathology based on classic fundoscopic exam findings. So in the rest of this video, we're going to go through a number of pathologies involving the retina and the macula, and for each one I'll try to show you a picture of what it looks like on fundoscopy. Let's start by talking about retinitis pigmentosa. This is an inherited retinal disorder. There are a number of inheritance patterns that have been described, including autosomal dominant, autosomal recessive, and X-linked. Children who are born with this condition have visual loss that usually begins in childhood. The reason they have visual loss is because in this condition there is loss of the photoreceptors, including the rods and the cones. Children with this condition have night and peripheral vision loss that occurs progressively. Their visual field becomes constricted, and unfortunately there is no cure. Most children born with this condition are legally blind by age 40. The classic fundoscopy finding in retinitis pigmentosa is intraretinal pigmentation, meaning dark spots on the retina in a so-called bone spicule pattern. This is an example of it shown on the screen here. You can see these dark spots in the periphery of the retina in the image on the screen. These dark spots are forming in the retina where the photoreceptor cells are missing. The term retinitis is really a misnomer in this condition. There's no inflammation of the retina, just loss of the photoreceptor cells, and when they are lost, they are replaced by these dark spots on the retina, which are present in the bone spicule pattern. Next, let's talk about retinitis. This is actual inflammation of the retina leading to edema and necrosis. Patients who develop retinitis may see floaters. These are dark spots seen in the visual fields. They may also have loss of vision. There are a number of potential causes of retinitis, but the classic cause that you should know is cytomegalovirus in the setting of HIV and AIDS. Usually the CD4 count needs to be very low, usually less than 50, for cytomegalovirus to be able to cause retinitis. You can also see this in transplant patients who are on chronic immunosuppression. The hallmark of retinitis on fundoscopy is the presence of retinal hemorrhages and a whitish appearance to the retina. This is an example of retinitis shown on the screen. It's often described as looking like a pizza pie in the back of the eye. Diabetic retinopathy is the term used to describe the retinal pathology that can occur among patients with diabetes, and eye complications of diabetes are very serious because they can potentially cause blindness. I talk about the pathophysiology of vascular disease in diabetes in the endocrinology section, but I just want to point out here that degeneration of pericytes are believed to be very important in the development of diabetic retinopathy. Pericytes are cells that wrap the capillary vessels in the eye and the retina, and when they degenerate, that can lead to development of microaneurysms. These aneurysms can rupture, and that can lead to hemorrhage, and this is believed to be very important in the mechanism of development of diabetic retinopathy. And it's because of retinal complications of diabetes that all of your diabetic patients will be referred for annual eye screening to detect complications early and treat them if they occur. There are two types of diabetic retinopathy, proliferative retinopathy and non-proliferative retinopathy. We'll talk about non-proliferative retinopathy first because this is the most common form of diabetic retinopathy. It's responsible for about 95% of cases, and it's so common among diabetics that it's often called background retinopathy. The earliest sign of background retinopathy is the development of microaneurysms. These are very difficult to see on fundoscopy. They are small outpouchings of the vessels in the retina. Another finding of background retinopathy is the presence of so-called dot and blot hemorrhages. These occur when a capillary becomes damaged and it leaks some fluid and you see small areas of blood in the back of the eye. Another characteristic of non-proliferative retinopathy is the presence of cotton wool spots. These are caused by nerve infarctions and occlusion of precapillary arterioles. This leads to these bright, fluffy spots in the back of the eye called cotton wool spots. You can also see these in patients with hypertension. This is not a unique finding to diabetic retinopathy. Shown on the screen is a drawing of what diabetic retinopathy could look like. I just want to point out to you the cotton wool spots here that you can see. You can find many other examples of this in your pathology textbooks and online. Also seen among diabetics with non-proliferative retinopathy is the presence of hard exudates and macular edema. This is damage to the macula portion of the retina. It's caused by macular swelling that leads to accumulation of yellow exudates of fatty lipids. If you look at this image on the screen, it's very easy to identify these hard exudates. These are these yellow things in the back of the eye. That is evidence of macular edema, and among all the features of non-proliferative retinopathy, this is the most dangerous because macular edema can potentially lead to blindness among patients with diabetes. The other type of diabetic retinopathy is called proliferative, and it gets its name because in this form of retinopathy there is vessel proliferation. This is caused by retinal ischemia, which drives new vessel growth. This is called neovascularization. You might think that new vessels are a good idea in the setting of ischemia. However, the vessels are abnormal, they're friable, and they often grow on the surface of the retina and can cause damage. They can lead to retinal detachment, which we'll talk about later in this module. They can also cause macular edema, which, as we just discussed, can lead to blindness. And this is a fundoscopic image of proliferative retinopathy. Notice the proliferation of small blood vessels in the retina. One of the reasons diabetics need to undergo annual eye exams is because if proliferative retinopathy is identified early, there are a number of effective treatments. One of them is photocoagulation, which basically means using a laser to burn blood vessels and stop them from growing. Sometimes a vitrectomy is performed. This is removal of part of the vitreous humor. This is often done when bleeding from the new blood vessels has occurred or when debris has accumulated. This can clear up some visual problems. And then finally, anti-VEGF inhibitors can be used. These are injected into the eye. They are intravitreal injections. One of them is called ranibizumab, and this can be injected into the eye and it can prevent further growth of blood vessels. Retinal detachment occurs when the retina peels away from the underlying choroid layer. And remember what I told you before, the choroid is the vascular supply to the retina. So when the retina loses its connection to the choroid, that can lead to ischemia. The photoreceptors, like the rods and cones, can degenerate, and this leads to vision loss, which is classically described as a curtain being drawn down over the eye. Retinal detachment is a surgical emergency because if vision is going to be restored, the retina has to be reattached in a timely manner. This is a fundoscopic image of a retinal detachment. If you look in the upper left of the image, you can see that the retina is folded on itself. It looks like crinkled paper. In many cases, a retinal detachment is preceded by something known as a posterior vitreous membrane detachment. If you look at this drawing of the eye, you will notice that the vitreous humor sits just inside of the retina, and the vitreous humor is surrounded by something called the vitreous membrane. If the posterior portion of this vitreous membrane is abnormally attached to the retina, it can lead to a retinal detachment. The way this occurs is that the vitreous normally shrinks with age, and if the vitreous membrane is attached to the retina, this can pull on the retina. This can cause small retinal holes or tears. This is known as a posterior vitreous membrane detachment. This can lead to the development of floaters or black spots. It can sometimes lead to flashes of light. So patients will sometimes develop this days, weeks, or even months before a retinal detachment. They will complain of floaters, and then at some point they will undergo a full-blown retinal detachment. There are some risk factors for retinal detachment that you should know. One of them is myopia or nearsightedness. I talk about myopia in detail in the video on the lens, but if you look at this picture on the screen, it shows an example of what happens in myopia. In myopia, the cornea creates a focal point that is in front of the retina. This can occur when patients have larger eyes. In other words, the eyeball is just a little bit too big, and therefore the focal point of the cornea does not fall on the retina. Instead, it falls in front of the retina. When patients have larger eyes, they tend to have slightly thinner retinas, and this sets them up for a retinal detachment. Patients who have had prior eye surgery or trauma are at greater risk for retinal detachment. And then I mentioned before that patients who have proliferative diabetic retinopathy have new blood vessel growth in the retina, and this can be a setup for a retinal detachment. Let's talk about a retinal vein occlusion. This occurs when there is occlusion of either the central retinal vein or a branch retinal vein, and this can lead to visual loss. If you look at this drawing on the screen, you will see that there are a number of retinal veins which coalesce into a central retinal vein. So a retinal vein occlusion can involve the central retinal vein, or it can involve one of the branches. A branch retinal vein occlusion is often caused by compression of the branch vein by retinal arterioles. This happens at places where the arterioles cross the veins. At these arteriovenous crossing points, you can develop occlusion of a branch vein. This often happens in the setting of arteriosclerosis. The sclerotic arterioles compress the veins. This is because they run together in a common sheath, and therefore when the artery becomes thickened, it can compress the vein, and this can lead to a branch retinal vein occlusion. A central retinal vein occlusion, on the other hand, is usually caused by a primary thrombus disorder, some form of a hypercoagulable state. The fundoscopic findings of a retinal vein occlusion are engorged retinal veins and hemorrhages, and the hemorrhages usually have a streaky appearance like the example shown on the screen. If it's a branch occlusion, you will see the hemorrhages in one portion of the retina. If it's a central occlusion, you will see the hemorrhages throughout the retina. So now we've talked about a retinal vein occlusion, but what happens if you have a retinal artery occlusion? This can lead to formation of something known as a cherry red spot on fundoscopy. A cherry red spot is a red circular area of the macula surrounded by a halo. This is an example of one shown at the bottom of the screen. The red spot in the middle of the image is the macula, and there's clearing around the macula, and that clearing is caused by ischemia. Now you can also see a cherry red spot in Tay-Sachs disease, which is a lysosomal storage disease. In that situation, the cherry red spot occurs because of accumulation of sphingolipids around the macula, and that leads to the halo around the macula and the cherry red spot. In the setting of retinal artery occlusion, the halo and the cherry red spot is caused by ischemia. The common etiology of retinal artery occlusion is a stroke, basically, from the carotid artery. So a plaque ruptures and leads to an embolus to the retinal artery, because recall that the internal carotid artery supplies the ophthalmic artery, and that supplies the retinal artery. You can also potentially have a retinal artery occlusion from a cardiac source. For example, if there's a thrombus in the left atrial appendage in the setting of atrial fibrillation, that can lead to a retinal artery occlusion. And then finally, a rare cause of retinal artery occlusion is giant cell or temporal arteritis. I talk about this in the vasculitis video in the immunology section, but this disorder involves inflammation of the blood vessels that supply the face and the head, and it can involve inflammation of the ophthalmic artery that can lead to occlusion of the retinal artery. Moving on, let's talk about papilledema. This is not exactly a retinal disorder per se, but it's an important finding on fundoscopy that you should be able to recognize. Papilledema occurs when there is optic disc swelling, and this is usually caused by increased intracranial pressure. In other words, it's a mass effect that leads to swelling of the optic disc. Because it's caused by increased intracranial pressure, it usually affects both eyes and therefore is often bilateral. And papilledema is characterized by blurred margins of the optic disc on fundoscopy. If you look at these two images at the bottom of the screen, the image on the left is a normal fundoscopic image showing very sharply demarcated edges of the optic disc. If you look at the one on the right, the edges are blurred, and this is what you see in papilledema. I'll finish this video by talking about disorders of the macula. As I mentioned at the beginning, the macula is an oval-shaped portion of the retina. It contains the fovea, and it's responsible for our high-definition color vision. You can see the macula on fundoscopic exam. It's a red circle off to the side of the optic disc. The major pathologic process of the macula is called macular degeneration. This commonly occurs as we age. In fact, it's sometimes called age-related macular degeneration, and many elderly patients have vision problems related to degeneration of the macula. In order to understand the vision problems associated with this disorder, you need to appreciate that the macula is very important for our central vision. Therefore, when it degenerates, this leads to a characteristic disruption of vision. First of all, there can be distortion of the visual fields. This is called metamorphopsia. In addition, there is often loss of central vision. This is called a central scotoma. A scotoma is a partial blind spot, and it's often central in the case of macular degeneration. Sometimes the visual fields are drawn, as I've shown on the screen, to indicate that the center of the visual fields is lost on both sides. And here's a picture from the web to help you better understand what the symptoms of macular degeneration look like. On the left side of the screen is a normal picture. On the right side is a picture as it might appear to someone with macular degeneration. Notice that the visual fields are distorted or blurred. Notice also that the central portion of the visual field has been lost. There are two types of macular degeneration. The first type is called dry macular degeneration. This is more common. It's responsible for about 80% of cases, and the symptoms of dry macular degeneration are generally slowly progressive. The less common type is wet macular degeneration, and this can develop rapidly with symptoms that occur over days or weeks. In order to understand the pathophysiology of dry macular degeneration, we need to talk about two important structures in the eye. The first one is called Bruch's membrane. This is the innermost layer of the choroid. It's the layer of the choroid that sits right between the choroid and the retina, right underneath the retina. So recall that the choroid is a vascular layer that sits just beneath the retina. The outermost layer of the choroid, the layer that sits just beneath the retina, is called Bruch's membrane. The innermost layer of the retina, the layer of the retina that sits right on top of the choroid, is called the retinal pigment epithelium. It's the retinal layer beneath the photoreceptors, and it's right next to the choroid, right next to Bruch's membrane. In dry macular degeneration, there is accumulation of something known as drusen. Drusen are yellow extracellular materials that form between Bruch's membrane and the retinal pigment epithelium. And this is what you want to remember for step 1 of your boards. If they ask you about dry macular degeneration, they are likely going to ask you where the drusen are found, and you need to know that they are between these two layers. This leads to a gradual loss of vision, as we discussed earlier, and unfortunately, for dry macular degeneration, there is no specific treatment. Luckily, it's slowly progressive, so it often doesn't result in complete visual loss, but the visual impairment usually cannot be reversed. There is some evidence that vitamins and antioxidant supplements may help slow the process, but in general, there is no treatment or cure for this condition. And this is a picture of what drusen look like on fundoscopic exam. Just get used to recognizing this image. You can see these yellow dots over the macula area of the retina just off the side of the optic disc. And if you understand the dry form of macular degeneration, then it's very easy to understand wet macular degeneration. In wet macular degeneration, there is a break in Bruch's membrane. This leads to the formation of blood vessels beneath the retina. Those blood vessels can leak and hemorrhage, and this can progress rapidly to vision loss. And wet macular degeneration can be treated with some of the same therapies that are used for proliferative diabetic retinopathy, including laser therapy and also anti-VEGF injections like ranibizumab into the eye. And here's a picture of what wet macular degeneration can look like. You'll notice that there is hemorrhage into the macula portion of the retina. And that concludes our module on